So today I've been charged with giving a talk on massive and submassive venous thromboembolic disease. We'll talk about diagnosis, treatment, and controversies. My talk is roughly 45 minutes in length, so feel free to, we get 15 minutes of extra time built in, so feel free to interrupt if you've got questions along the way. So this is the typical logistic information on venous thromboembolic disease that occurs before most of these lectures. The incidence is about 300 to 600,000 cases per year, and 1 to 2 per 1,000 in the population. And like a lot of other diseases that we see, this is a disease of the aged. So if you're older than 80 years old, it can be as high as 1 in 100 patients. Estimates suggest that between 60 and 100,000 Americans die of DVT or pulmonary embolism each year, and about 10 to 30% of the people who die will die within a month of their diagnosis. In those individuals, sudden death is the first symptom of 25% of the people who have a pulmonary embolism. And the death rate, based upon 1998 data, and unfortunately that's the most recent that I could find, is about 94 per 1 million. About a third of individuals with DVT and pulmonary embolism will have a recurrence within 10 years. Okay. So first case. This is a 45-year-old female with no significant past history on oral contraceptive, who presents with chest pain, dyspnea, and lightheadedness. She is pre-syncope, but she does not pass out. On physical examination, she's hypotensive at 75/50 and doesn't improve after 2 liters of normal saline. Her heart rate is 120 beats per minute in regular, and her respiratory rate is 20 beats per minute. The rest of her physical examination is normal. This is a pulmonary embolism protocol CT scan, and I'm going to presume that you don't need a degree in radiology to see that there's a big clot in the right main stem pulmonary artery and the left main stem pulmonary artery, and then there's a clot that traverses the bifurcation trunk. So what is the next step in the management of this individual? So this is what people would identify as a massive pulmonary embolism. An universally accepted definition of a massive PE is a systolic blood pressure of less than 90 for at least 15 minutes. A blood pressure drop of at least 40 millimeters of mercury from baseline blood pressure for at least 15 minutes. And the hypotension cannot be due to a secondary etiology. So, for example, it can't be due to an arrhythmia, hypovolemia, sepsis, or other distinct etiologies. Now, there's some controversial definitions as to what makes someone have a massive pulmonary embolism. And I'll dive into most of these throughout the course of my talk, but I just want to let you know that this is an area of controversy in the literature. So if you had some people say at least 2 of the following echocardiographic findings of right ventricular pressure overload in the absence of either left ventricular disease or mitral valvular disease. So right ventricular dilation with a right ventricular size less than left or greater than left ventricular size. Typically, most literature will support an RV to LV ratio of greater than or equal to 0.9. Paradoxical septal wall motion, loss of inspiratory collapse of the inferior vena cava, tricuspid regurgitation, which on echo can sometimes show a jet velocity of greater than 2.8 meters per second, and precapillary pulmonary hypertension, which identifies a mean pulmonary artery pressure of greater than 20 with a normal pulmonary artery occlusion pressure. Okay, so why is it important to distinguish? This is a study done by Kutcher and published in Circulation in 2006, and this is based upon the ICOPER data set. That's the International Cooperative Pulmonary Embolism Study. I'll go through the specifics of that a little bit more in a bit, but basically to outline here, the difference between a massive and a non-massive pulmonary embolism can be the difference in mortality. So the individuals that have a massive pulmonary embolism typically have about 90 days, have a mortality rate of about 50%, whereas the non-massive pulmonary embolism has a mortality rate somewhere around 15 to 20%, and the p-value between the two differentiates enough that makes it statistically significant. So let's talk a little bit about massive pulmonary embolism, which I'm going to define here exclusively as hypotension. This was the initial study that looked at thrombolytic therapy for pulmonary embolism. And as you can see, 8 total patients. Half the patients got heparin alone, half the patients got streptokinase plus heparin. And as you can see, all the individuals that just got heparin died. All the individuals that got streptokinase plus heparin lived. And that gave a p-value of 0.02, making this statistically significant. Since 1995, there's been over 70,000 patients that have been studied with massive pulmonary embolism or thrombolytics for hemodynamic instability. And this is a study done by Paul Stein. It's a meta-analysis looking at, again, 70,000 patients that came in and were presented with massive pulmonary embolism. And they look at all-cause fatality rate for the patients that received thrombolytic therapy versus the patients that did not receive thrombolytic therapy. And as you can see, the ones that were treated with thrombolytics had a mortality rate of 15%. This is an important number, keep it in the back of your mind. Whereas the ones that did not receive thrombolytic therapy had a mortality rate of about 50%.
Mike, were these studies, were they predominantly studies of comparisons, predominantly studies where people did one thing or the other and they're just being put together? Or?
I'm not sure I understand your question.
So the studies that these 70,000 patients, are they studies where the physicians are doing some sort of random or non-random assortment?
Yeah, so it's all patients. It's patients that, I mean, there were criteria for pulling this study in. And I don't recollect if it actually had to be a randomized study, but these are individuals that were treated, the group that received thrombolytic therapy, they got standard thrombolytic therapy versus the individuals that did not receive
some sort of
heparin.
Comparison.
Correct.
Can you say how the thrombolytic therapy is given?
This is in this meta-analysis, it's typically 100 milligrams of TPA of alteplase equivalent. So these are individuals that received full dose venous thrombolytics. No other means of therapy. No, we'll talk about that in just a second. Okay, so other options that you have for treating an individual with a massive pulmonary embolism is a surgical embolectomy. Now, some individuals will argue that this is salvage versus primary therapy, and it really depends upon your local surgical expertise. So, for example, if you have a patient that comes into Henry Ford in Detroit, and you think that they may be a candidate for an embolectomy, you can actually call the cardiac surgeon and potentially get that done. Whereas if those individuals present to West Bloomfield, you don't have that option on the table. Now, Paul Stein, when he did his review of this group of individuals that received surgical embolectomy, he actually had two distinct groups of patients. There was patients that were treated from the 1970s through 1985, and then the ones from 1986 through 2006. Sorry. The reason I chose the second group is because the surgical technique to perform surgical embolectomy changed around 1985, and that's why he divided them, and that's why I think we should just look at the second group of patients, because that's using modern techniques in terms of removing the clot. In this group, there were 253 patients, and there were variable reporting on outcomes. Now, things that were important in these groups, again, this is a meta-analysis. About 20% of the individuals that received surgical embolectomy had a contraindication to thrombolytics. The mortality in the group that received surgical embolectomy is roughly 20%. About a quarter of them had a preoperative cardiac arrest, but only 75% of them had hemodynamic instability. So you can make a very cohesive argument that this group of patients is very different than the group of patients that received a thrombolytic therapy. Now, in this study that was done in 2006, they looked at individuals that came into the hospital and had received thrombolytic therapy for hemodynamically unstable pulmonary embolism. And then what they did is they randomized those individuals who remained clinically unstable to receiving a surgical embolectomy versus a second course of thrombolytics. As you can imagine, the number of individuals in this study is extremely low. But as you can see, the individuals that received the surgical embolectomy as salvage had a mortality rate of about 10%, whereas those individuals that received a second course of thrombolytics actually had a mortality rate much higher. So you can make a very cohesive argument that if I see a patient that comes into the hospital with a massive embolism, that I potentially can give him TPA first, and if it fails, then involve the cardiac surgeon and consider a surgical embolectomy at that point.
In this study, slide before at the date, control for the degree of hypoxia, especially those with hemodynamic state.
These are meta-analyses, so not all studies, especially in the surgical embolectomy literature, not all of the studies actually comment on hemodynamics. They don't comment on degree of hypoxemia. They don't comment on vasopressors. A lot of them will put all that stuff in, but they don't always.
In that previous slide, when they were determining who to do the embolectomy on, and they were hemodynamically stable, in that 75%, they must have been hypoxic.
Or they had just large clot burden, and somebody said we should take that out because. And I'll talk a little bit more about that in just a few moments as well.
It's not a contraindication to get surgery after thrombolytics, but I have a situation that the surgeon did not want to do that with an indication because the patient got thrombolytics and it's like, if he called me before, I would have done it, but now.
Yeah, I mean, this study shows that it can be done.
Yeah, it can be.
Yeah. So this is another study that looks at surgical embolectomy outcomes. I just wanted to show a specific intervention. In this intervention specifically here, the individuals that got a surgical embolectomy had a mortality rate of about 17%. But once again, in this specific study, not all the patients have what we would define as a massive pulmonary embolism. So a lot of times in the surgical embolectomy literature, at least the stuff that I saw, they cherry pick their patients. They pick the ones that are, quote, the good surgical candidates and not necessarily ones that all have massive pulmonary embolism. Okay, let's move on from surgical embolectomy to catheter embolectomy. So there's been small case series regarding several techniques that are both prospective and retrospective. None of these studies compare to conventional therapy. So none of them compare a catheter-based embolectomy to thrombolytic therapy. This is a meta-analysis of 35 studies that had 594 patients. And then the forest plot looks at, quote, success rate. And the problem with success rate is it's not always an endpoint that all of us would be comfortable with. So the endpoints was stabilization of hemodynamics, or resolution of hypoxia, or survival from massive pulmonary embolism. But as you can see, based upon this study, the forest plot shows the p-value being 0.004 in favor of the catheter-based embolectomy for a success rate. This is one retrospective study that was pretty simple to look at. This is using an angiojet catheter. The angiojet catheter is a catheter basically that you put in, and at the distal end of the catheter in here, they basically push saline through at very high velocities. What that effectively does is it creates a vacuum or a Bernoulli effect in here that basically fragments the clot, brings it back up, and then allows it to recirculate. So effectively breaks down the clot at the same time. Excuse me. This was a study done in 17 patients. Again, not real robust study, certainly from our standpoint. And it was a retrospective study looking at these patients with massive embolism. These patients all had hemodynamic instability. They had a percutaneous mechanical thrombectomy in these 17 patients. 10 patients had local infusion of thrombolytic therapy for a residual clot, and 12 of the 17 received an inferior vena cava filter. So the mortality rate in the study is 2 of 15 or 17%. Roughly what we say, again, about the same number that we saw in the patients that received thrombolytic therapy, but not nearly as robust. So here's my apples to oranges study. So if you look at the clinical success rate, again, depending upon which study you look at, mortality is not always the outcome that you look that is being described. But in the Stein study, the mortality benefit was the mortality rate was 15%. In the catheter-based study, again, also looking at hemodynamic improvement and hypoxia, the success rate was 86%, and in the surgical embolectomy rate, it's about 80%. So you're looking at roughly the same outcomes no matter which means of therapy you put, depending upon how you interpret the studies that are available to us. Okay. So a lot of people say, well, the reason that these things work better is that it improves embolic obstruction. That's what we're doing. We're giving thrombolytic therapy. We're improving the embolic obstruction, and then that's why patients are living longer. Well, that's true. So this is a study also a meta-analysis that looked at several different studies, and I like this because what it shows you is that at day 1, 24 hours, you do see improvement in ventilation perfusion scan studies. So you have improvement of your clot burden at day 1. But as you can see, at a week and at 2 weeks, it makes absolutely no difference whether you give thrombolytic therapy or not. Patients will resolve with anticoagulation alone. So you get better upfront treatment, but long-term, at least 7 to 14 days into it, there's no difference in terms of overall outcome and clot burden improvement. Okay, so I mentioned I would talk about the Intracranial Cooperative Pulmonary Embolism Registry study. This is a study that was done by Sam Goldhaber and ultimately is what made him famous. It's an observational, non-randomized, database study of 2,400 patients in which 108 patients had a massive pulmonary embolism as defined by blood pressure measurements with a systolic of less than 90, and 2,284 patients in which they had a non-massive pulmonary embolism. So in the patients that had massive pulmonary embolism, again, it's 108 patients. They said to the team, do whatever you want. We're just going to study what you did. They looked at these individuals, and the individuals that received an inferior vena cava filter had an improved outcome versus the individuals that did not get an inferior vena cava filter. Again, not a robust study, not a robust sample, but nonetheless, this is the best data that we have. So you can make a very cohesive argument that if you've got an individual with a massive pulmonary embolism and you treat it, that you probably ought to put a filter in because they're not going to handle the next hit that they're going to potentially get. just as a counterpoint to that, this is a DeCousa study published in the New England Journal of Medicine in 1998. They looked at patients who had non-massive pulmonary embolism, and they received an IVC filter. In this, the individuals had free-floating clot in the lower extremity. So they looked at the time at 12 days after randomization. They looked at time points at 2 years after randomization. And at no point in this study did it matter from a mortality perspective whether patients did or did not receive a filter. However, at 12 days after randomization, you have a much lower rate of recurrent pulmonary embolism. But 2 years after randomization, the individuals that got a filter had a higher rate of recurrent DVT. Now, when this study is published, we don't have access to the retrievable filters as of yet. So it's feasible to make an argument that if you've got somebody that's got a big clot or submassive embolism, and you're worried that the next hit could be the fatal one, that maybe a retrievable filter might be the right thing to do for that individual. But you got to make sure you take it out. Okay. Let's talk a little bit about thrombolytics, because these things don't come with... Oh, I'm sorry, Zach, go ahead.
Just a quick question. How long do you leave them in before you take them out?
Somewhere between 12 days and 2 years.
Yeah, so the filter has to come out within 3 months. The interventional radiologist can't take them out if they're in longer than 12 weeks. So most individuals will tell you that you want to leave them through the quote instability phase of it, so the first couple of weeks, and then have them on anticoagulation to come back and have the filter removed. My personal practice, although there's no data to back it up, I typically about 6 to 8 weeks is when I'm sending about to IR.
But after 3 months, you can't.
3 months, 3 months, the interventional radiologists will tell you it's very difficult / impossible to take them out.
Do the anticoagulants need to be stopped for a short time to take it out?
In the 3 cases that I've sent down, they say no. They'll do it on full anticoagulation with warfarin. Yeah. Okay, so let's talk about the risks of thrombolytics. This is the one that we all care about, bleeding. The risk of major bleeding in individuals that receive thrombolytics in this study by Chatterjee was about 9%, and that's pretty much uniform across most of the studies. Somewhere between 5 and 10% of individuals will have major bleeding, whereas the individuals that have anticoagulation typically somewhere less than 5%. In this study, with the use of thrombolytic therapy, the number needed to harm for thrombolytics is 18. So you're going to cause an episode of major bleeding if you give thrombolytics if you give it to 18 patients. However, when they drill down a little bit further, what they also noticed is that there's no significance if you have a younger patient. So in a young patient, someone less than 65 years old, there's no difference between heparin and thrombolytics in terms of major bleeding risk. But if you have an older patient, your risk of bleeding goes up. This is the one that we all care about even more. This is intracranial hemorrhage with thrombolytic dose of less than 100. So in the Dahlin and Alport study, they showed an incidence of intracranial hemorrhage in about 2% of patients. I oftentimes will hear the cardiologists tell me, oh, there's no risk of thrombolytics. We never see it in our studies. And they don't. It's less than 1% in both TIMI 2 and Gusto. The problem is our patients have at least a 2, maybe a 4-fold higher risk. Our patients tend to be sicker, and they tend to have more than just single organ damage. So your risk of bleeding in the brain, again, most studies will confirm this, is roughly 2%. Okay. Case. Yeah. This is systemic TPA. That's correct. I'll talk a little bit more about other means of delivering TPA later in the talk. I'll get to that. So case 2, same patient, 45-year-old female, no past history, on oral contraceptive, presents with chest pain, dyspnea, and lightheadedness. This time the difference is this individual has a blood pressure of 115/70. She's still tachycardic, she's still tachypnic, and the rest of her examination is normal. I'm going to give you the same CT scan, but in this case I'm going to give you an echo. The echo shows mild to moderate right ventricular hypokinesis. It shows septal flattening, a dilated RVC with lack of respiratory collapse, an elevated pulmonary artery pressure, but normal left ventricle and normal left ventricular dimensions and normal mitral valve. So what's the next step in the management of this individual? And this is where all the controversy starts. This is actually what's considered a submassive pulmonary embolism. So let's talk a little bit about what right heart failure means, and let's talk about outcome. So this is right heart abnormalities in individuals that have both massive and non-massive pulmonary embolism. And as you can see, this is again taken from the ICOPER data set. If you have a massive pulmonary embolism, the incidence of having right ventricular hypokinesis is about 65%, double that of what an individual has a non-massive embolism. Same thing with right heart thrombi. It's essentially double that of an individual who has a non-massive embolism. What I want you to take away from this slide is this is not zero. You will still, in non-massive pulmonary embolism, see right ventricular abnormalities. You will still see right heart thrombi. And right ventricular dysfunction is the same thing. This is a different study, but it shows essentially the same thing. In an individual that has right ventricular dysfunction, their mortality is much higher than the individuals that do not have right ventricular dysfunction, both from total mortality as well as mortality from pulmonary embolism. So what is right ventricular dysfunction? This is, again, where the literature is not uniform in terms of what they use. The most often cited reasons that patients are diagnosed with right ventricular dysfunction is they have a dilated right ventricle in the absence of hypertrophy. They have paradoxical septal motion, or they have Doppler evidence of pulmonary hypertension. But they don't have to have all of these or one of these, and some studies will use additional criteria to document exactly what right ventricular dysfunction means. Okay. So right ventricular dysfunction, hemodynamics, and mortality. This is a study done by Grafoni and published in Circulation in 2000, in which he looked at individuals that were normotensive and hemodynamically stable, normotensive with and without right ventricular dysfunction. So in the group on the left, those individuals were normotensive, they have no right ventricular dysfunction, and they had a mortality rate of about 3%. On the right, that they were normotensive, they did have right ventricular dysfunction, but they were hemodynamically stable. Okay, great. So this is what you told me before. What's the big deal? 0% of the individuals on the left side will go on to develop shock. But 10% of the individuals on the right side will go on to develop shock. And these are the patients we have to be careful. These are the patients we have to know about, because those are the ones that are going to get sick on us later, and we ought to be able to figure out what to do for them both beforehand and then during the time that they do get sick. So what does right ventricular dysfunction really mean? Well, it suggests that it's predictive of an adverse outcome. But I haven't shown you any data yet showing you we should do anything different in terms of management of these individuals. How about right ventricular enlargement? So we talk a lot about, well, the echocardiogram shows us right ventricular enlargement. So we're waiting on a cardiologist to come by and do an echocardiogram and tell us what the right ventricle looks like to the left ventricle. This is a study that looked at individuals that had CT scans, and they looked at the CT dimensions. And if you have a right ventricular diameter to left ventricular diameter that's less than or equal to 0.9, your outcomes are distinctly better than individuals that have right ventricular dimension to left ventricular dimension. So the people, you can actually, when you get your CT scan, just measure the size of the right ventricle and compare it to the size of the left ventricle, and you'll know right away whether a patient has right ventricular abnormalities. That will tell you a lot of information. You're getting this when they come up anyway. It's simple enough to do. The problem is there's still no studies that show whether cardiac dimensions when reconstructed CT should guide treatments, and more importantly, the studies showing that they correlate perfectly with echocardiographic findings are not there either. Okay, right heart thrombi. So this is again taken from the ICOPER data set. These are individuals that, again, 2,400 patients, about 1,000 of them had echocardiograms in which they could interpret the right side of the heart well, and about 975 of them had no right heart thrombus. About 37 of them did have a right heart thrombus. And as you can see, the 90-day mortality amongst the individuals that had a right heart thrombus was greater than the individuals that had a left heart that did not have a right heart thrombus. The problem is when you start looking at all the other variables and what they're measuring, right heart thrombi actually come out. So if you look, it goes through 0. So right heart thrombi is not predictive of somebody who's going to die. Maybe it's just predictive of an individual who's got right ventricular hypokinesis, and that's the third variable you need to look at. You'll also note that in this specific portion of it, systolic arterial pressure of less than 100 was not predictive of mortality. The problem is that the universally accepted definition for massive pulmonary embolism is less than 90. This is that same study by Torbicki, in which they looked at, well, okay, fine, you have 30 some odd patients that are being managed that have right heart thrombi. What did they do, and what was the outcome in them? And it turns out they have a high mortality no matter what you do. If you put them on heparin, their outcome is the same as whether you give them thrombolytics versus if you do an embolectomy on them. So it doesn't really make any difference how you treat them, at least on this observational study. Right heart thrombi are potentially bad, but we still don't have an effective means of therapy that's better than giving heparin alone. This is a study that was done it was a free floating right heart thrombi. So these were thrombi that were floating in the wind. And again, there's no statistical difference between no matter which way you treated these individuals. You'll see mortality rates in this study that are much higher than the previous one I told you, and you also see that trend towards improvement in thrombolytics. The problem is that your N is really low, and that's probably that's potentially creating an error that's preventing you from determining whether there is a benefit in giving thrombolytics to individuals with right heart thrombi. Okay, so in 2002, Constantinides did a study that he looked at submassive pulmonary emboli and thrombolytics. So he said, well, these patients are sicker. Let's look at their right heart function. I've already shown you the mortality is worse. I've already shown you that their mortality from PE is worse. So let's look at these individuals. Maybe they'll benefit from giving thrombolytics. And he took 250 patients in a randomized fashion, and these individuals had to have a documented pulmonary embolism, and they had to have right ventricular dysfunction in the absence of shock. So these are hemodynamically stable individuals. He defined right ventricular dysfunction as right ventricular enlargement in the absence of left ventricular disease, echocardiographically detected pulmonary hypertension, precapillary pulmonary hypertension by right heart cath, or new EKG signs showing right ventricular strain. And on first blush, it looks like we have a winner. So if you give heparin plus alteplase in the individuals who have submassive pulmonary embolism versus heparin alone, you have a distinctly different mortality, you have a distinctly different outcome rate. The problem is they use probability of event-free survival as their endpoint. What does that mean? Well, here's the endpoints that they used. So the primary endpoint was death from all causes. No statistical difference between the two groups. The difference comes in escalation of treatment. And it's not from catecholamine infusion or endotracheal intubation or cardiopulmonary resuscitation or embolectomy or thrombus fragmentation. It comes from secondary thrombolysis. This is a European study. The Europeans believe thrombolytics work. They were studying whether thrombolytics work, and they used off-label use of thrombolytics as an endpoint. That's probably not the appropriate way of doing a study. And there's where all your statistical differences come from. If you look at the other events that you care about in this, death, intubation, catecholamine, CPR, and embolectomy, there's no difference between any of these variables. The only difference was secondary use of thrombolytics, or off-label use of thrombolytics. So earlier in the talk, somebody said, well, is radiographic clot size important? Let's talk about saddle pulmonary embolism for a minute. So the definition of a saddle embolism is a visible thromboembolus straddling the bifurcation of the main pulmonary artery trunk. This is, again, big pulmonary embolism sitting in the main stem trunk going into the left and then the right main pulmonary arteries. This is a patient here that was treated with heparin and warfarin. There was CT resolution of this clot after 32 months, and the transthoracic echocardiogram after 32 months showed estimated RVSP of 26. So Roux looked at a retrospective analysis of 550 patients in which they found a saddle embolism in 14 of them. There was shock noted in 14%, and thrombolytics were given in one of those two patients. There was right ventricular dysfunction in 80% of them, but there was no deaths during hospitalization. So truthfully, saddle pulmonary embolism in and amongst itself is scary, but it doesn't actually predict whether somebody's going to die of their disease in the absence of other abnormalities that we see. Okay, can serologic studies help direct therapy? So I'm going to give you the exact same patient. Hemodynamically stable patient who comes in with a pulmonary embolism, but I'm going to give you some more stuff. I'm going to give you a troponin of 1.8. I'm going to give you a lactate of 3, and I'm going to give you a B-type natriuretic peptide of 581. Does this make a difference in terms of what we're going to do? So this is a receiver-operated curve for individuals who have a BNP. And a diagnosis of a pulmonary embolism with a BNP of greater than 100 gives you an odds ratio of right ventricular dysfunction of roughly 40. So if you see a patient that comes in, you're looking at the information in front of you, you've got lab tests and a CT scan. If you've got a BNP of greater than 100, you're pretty much assured that this patient's going to have some right ventricular abnormality. It's nice and predictive of it. The BNP also predicts whether that patient's going to die. So if you look at this study, it's a meta-analysis of elevated BNP, i.e. greater than 100, and the mortality rate is much higher. As you see, the triangle doesn't cross the union line. How about troponin? Same thing. So if you see a patient that comes in with an elevated troponin, you're more apt to have, they're more apt to die of their pulmonary embolism than an individual that does not have an elevated troponin. They're so much more apt to die, their mortality rate from an elevated troponin is roughly 20%. So these are individuals that are sick, no doubt about that, whereas a normal troponin puts you down at a mortality rate of about 5%. Same thing as the general community. who comes in with a PE. And this is actually one of my favorite studies when researching this. This is a study that...
Is that all PEs or just hemodynamic ones? All PEs?
All PEs. All PEs with it. No, yeah, this is all PE. This is all pulmonary embolism. Yep.
And this is any abnormally elevated troponin
Anything.
Beyond a certain cutoff. Anything abnormal.
Yep.
Okay.
So this is a study that looks at lactate. Manny, I think, might have been on to something. So as you look, every level your lactate goes up, your mortality goes up. The lactate is a predictor of perfusion abnormalities. And if your perfusion goes down, your lactate goes up. It does predict how somebody's going to do long term. This is actually even in this one specific study, it's 125 prospective patients. The lactate level is by far the best predictor of all-cause death. It's better than shock, it's better than right ventricular dysfunction, and it's better than troponin. So an elevated lactate level should make you even more nervous that the patient's sick. So I showed you the Constantinides study before. This is the PETHOS study, the pulmonary embolism thrombolysis trial, intermediate risk pulmonary embolism. So in these individuals, they had a diagnosis of a PE, they had right ventricular dysfunction, and now they're serologic abnormalities. They have an elevated troponin. So should we give thrombolytics for submassive pulmonary embolism? In this group of patients, there's a composite endpoint again of death plus hemodynamic decompensation. And if you look at the composite endpoint, yes, the patients that got thrombolytic therapy, tenecteplase at 100 milligrams, had an improved outcome. Once again, the problem is that when we start looking at the hard endpoints that we care about, it didn't make any difference in terms of death. So the outcome in terms of dying was exactly the same whether they got thrombolytic therapy or whether they got heparin therapy. The whole statistical outcome was improved by giving the patients with hemodynamic decompensation. So let's drill down a little further, let's talk a little bit about the side effect profile. Again, thrombolytics are not benign drugs. You had a major extracranial bleeding, once again between 5 and 10%. That's pretty much uniform across the medical literature. Minor bleeding up at about 30%. And then hemorrhagic stroke, again, up at somewhere around 2 to 3%. Exactly what I showed you from the data of Halpern in 1997. So we're no better at this now than we were before. So what if I wait? So this over here, the submassive pulmonary embolism is your mortality rate from the individuals that were given heparin plus thrombolytic therapy. Again, roughly around 2%. This is a subgroup of patients that were given placebo. There were 23 patients in this study. There are 23 patients in this group. They received placebo, became hemodynamically unstable, and then were given thrombolytic therapy. And their mortality looks just like the thrombolytics in any study, about 15%. So if I wait, these individuals have the exact same mortality than if I give them thrombolytics up front, and moreover, they actually don't have the risk of intracranial hemorrhage or bleeding risk. So waiting is not necessarily bad. Pulmonary hypertension. Now I know Sarah's going to talk about this in a lot more detail in 2 weeks, but Jeff asked me to talk about this too, so I'll dive into this very briefly. So if you look at individuals that come into the hospital who have right ventricular hypokinesis after a diagnosis of VTE, the individuals that get heparin have a much lower rate of right ventricular abnormalities than the individuals that get heparin and alteplase. That's probably not surprising to you. The individuals that get heparin plus alteplase are typically sicker. They typically have higher incidence of these things, so it doesn't surprise you, at least didn't surprise me, that on diagnosis they're higher. But the thing to pay attention to is that at 6 months, the number is exactly the same, whether they got alteplase up front or whether they didn't get alteplase up front. This is pulmonary hypertension. So the individuals that will have an RVSP of greater than 40, this is all comers in this study, is around 30 to 35%. At time of diagnosis. At 6 months, your incidence of pulmonary hypertension is roughly between 5 and 10%. So this is a study published by Guerin in 2014, 146 patients with PE proven on CT or ventilation perfusion scan. They did an echocardiogram following these patients for up to 2 years. Chronic thromboembolic pulmonary hypertension was confirmed if they had a pulmonary artery pressure of greater than 25 and one segmental perfusion defect on a ventilation perfusion scan. The prevalence of this is about 5%, and their risk factors are things that you probably, if we sat down and talked about it, would be common things. So previous PE, older patients, proximal PE, high levels of systolic pulmonary artery pressures at time of diagnosis, and a high level of BNP at the time of diagnosis. So this is a study that looks at the cumulative incidence of chronic thromboembolic pulmonary hypertension. The reason I put this on is that point right there. That inflection point in which you don't see any more pulmonary hypertension is 2 years. So if you follow these patients in your clinic and you get an echo at 6 months and then you get an echo again in about 2 years, your incidence of diagnosing pulmonary hypertension, chronic thromboembolic pulmonary hypertension goes away. So after 2 years, if they don't have it, the likelihood is that they're not going to get it. So what's next? So the question that I asked as I'm going through the literature to try to find this is, what if I found a treatment that has the same risk profile as heparin, but was more effective at treating right ventricular dysfunction in an individual that has pulmonary hypertension, or that has a pulmonary embolism? This is a study published last year by Niels Kucher in 2014. It's an ultrasound-assisted catheter-directed thrombolysis, and the cardiologists here do this. Acute pulmonary embolism, these patients were hemodynamically stable. They had a right ventricular to left ventricular dimension of greater than 1, and they got randomized to either unfractionated heparin plus ultrasound-directed thrombolysis, in which they received a total dose of 10 to 20 milligrams of TPA. This answers your question, Julio, and or versus unfractionated heparin. So in this study, I would butcher it if I tried to explain it myself, so I figured I'd just highlight it and show it to you. The ultrasound-directed thrombolysis is basically combines conventional catheter-directed thrombolysis with high-frequency, low-power ultrasound. It can't dissolve the thrombus, but it fragments it, and it increases the thrombus permeability to thrombolytic drugs. In addition, the thrombus penetration of thrombolytic drugs is enhanced by the acoustic streaming from the ultrasound pressure waves. It sounds a lot like voodoo to me, but nonetheless, that's what they say. So this is the data from the study. So if you look at the individuals that got ultrasound-assisted thrombolysis plus unfractionated heparin and compare them to unfractionated heparin alone, there was at day 1 there was an improvement in the RV to LV ratio, less abnormalities echocardiographically versus the unfractionated heparin. The p-value is different between the individuals that got unfractionated heparin at day 1. Like all the other studies that I've showed you, at 90 days, it doesn't make any difference how you treated these patients. So these are the individuals that you're giving therapy to that you're worried about more up front. But at 90 days, if they live, they're going to look exactly the same irrespective of how you treated them. More importantly, what are the adverse outcomes? Well, there's really relatively little bleeding. 3 minor bleedings in the ultrasound group and 1 minor bleeding in the heparin group, arguing that maybe lower dose thrombolytics are the right answer. And there were no deaths in the ultrasound group and only 1 death of pancreatic cancer in the heparin group. So the second potential way of solving this problem is using a lower dose or, quote, safe dose thrombolytic therapy. The rationale is the lungs see 100% of the cardiac output, whereas other organs see significantly lower amounts. So if you're giving thrombolytics for an acute coronary syndrome, they're not seeing the coronaries don't see all 100 milligrams of TPA. So if you have a moderate pulmonary embolism, and you have a CT pulmonary angiogram with involvement of 70% of the thrombus and greater than 2 or lobar or left or right main stem pulmonary arteries, the dose of thrombolytics was in this study was was up to 50 milligrams. So you give 50 milligrams of TPA, or if you were weighed less than 50 kilos, you gave less than that. Excuse me. And here's your outcomes. The follow-up for these patients was a little over 2 years. There was no difference in mortality. There was a lower incidence of recurrent pulmonary embolism in the individuals that got thrombolytic therapy up front versus the individuals that did not. And more importantly, from my standpoint, there was no bleeding in either group. This is a 125 patient study. The reality of this is it probably needs to be studied better, and maybe what we need to do is figure out which patients are the ones that we're the most worried about and maybe use a lower dose of thrombolytic therapy. The thing that I can't figure out in this study is the incidence of pulmonary hypertension is really high in the individuals in the anticoagulation group, and arguably it's much higher in the individuals that receive thrombolytic therapy. Again, at 2 years, I showed you before that the incidence rate of pulmonary hypertension is about 5%, depending upon which study you look at. This, you're talking pulmonary hypertension in the range of 50%. So here are my summary slides. Revascularization therapy is indicated in patients who have a massive pulmonary embolism, as indicated by refractory hypotension. Systemic thrombolytics, catheter interventions, and surgical embolectomy probably have identical outcomes, but unfortunately there's no head-to-head comparisons. In patients who have a massive embolism, placement of an IVC filter should be strongly considered. Right heart pathology is indicative of a worsening prognosis in venous thromboembolic disease. The problem is there's no studies to date that indicate we should do anything more than just anticoagulation. Now, you can make an argument that maybe with a high lactate level, and maybe with a high troponin, or maybe with a high BNP, or maybe the really bad right heart pathology, we ought to consider something more. Large clot burden, i.e. saddle embolism, is not an indication for thrombolytic therapy in the absence of hemodynamic instability. And serum biomarkers, troponin, BNP, and lactate, do worsen the prognosis from venous thromboembolic disease. The current data still favor treatment with anticoagulation, but if you're going to study something, this is the place to go after. Find the right heart pathology, find the patient with the elevated lactate, and then see what we can do with those people. Echocardiography 6 months after the diagnosis to assess for pulmonary hypertension, and the risk for chronic thromboembolic pulmonary hypertension is ongoing for up to 2 years. Perhaps lower dose thrombolytic therapy, up to 50 milligrams of TPA, or ultrasound-assisted catheter-directed thrombolysis will be the treatment of choice in patients with submassive embolism in the future. But we need more studies, we need more data to help define the correct patient population. That is all I have. Does anyone have any questions for me?
How would you feel about ultrasound-assisted in a patient with massive pulmonary?
The catheter-based thrombolysis is essentially the same, at least mortality-wise from what we see right now, to that of thrombolytic therapy. If you can get it done fast and in a rapid fashion, I don't see that being any different than any of the other catheter-based interventions, so I don't have any problem with doing it that way.
Sometimes it's done as a secondary after the first initial thrombolytics. Didn't work. You give the catheter.
Yeah, salvage therapy, the ability to find data in individuals with massive embolism for primary therapy is difficult. Getting data for salvage therapy is even more difficult. The only salvage therapy data I showed you was the embolectomy data. When you're sitting with a patient that's hemodynamically unstable after the diagnosis, after the treatment of thrombolytic therapy, anything you can do to help restore their perfusion, I think is fair game at that point. Yeah.
Sounds like my practice of after pulmonary embolus of getting an echo 6 months later, and it's normal, and I breathe a sigh of relief, is probably not long enough then, from what you're saying, correct?
Probably not long enough. This, and again, I'm going to let Sarah probably address this a little bit better in a couple of weeks, but you can see that you still see evidence of the cumulative incidence. You still see evidence even after a year of higher numbers of individuals that go on to develop it. I'll be frank with you, my understanding of pulmonary hypertension is about that big, so I usually rely on that turn around to educate me. Likely vascular remodeling may be occurring even in the setting of individuals who have that, but I'll defer that to someone who's a lot smarter than I am.
Because another subgroup that you see periodically is the ones that have the increased right ventricular strain during the embolus. Then I do it 6 months later, it's normal. And I've been breathing a sigh of relief. Going to get better like that and then get worse again? I guess is the question there. So
I mean, this is just one study that looked at this. Again, I'm hoping that Sarah will address that, but I don't know. Yeah, Chris, what can I?
From an ED standpoint, they're getting tropes and BNPs downstairs to kind of stratify and decide whether a unit versus tele. What are your thoughts? Hemodynamically stable, the BNP and a trope. Do they need the unit? Do you think tele's okay?
Those individuals that have right heart dysfunction, and arguably the BNP is a predictor of right heart dysfunction. If they're hemodynamically stable with right heart dysfunction, even at point X, their chances of decompensating is about 10%. So when you've got an individual that's got a 10% chance of decompensating, I don't know, to me that's good enough to put them in the unit. But I don't, clearly there's other criteria that people will use to put somebody in the ICU, and I will defer to making it a case-by-case basis. But I think honestly, if somebody's got a 10% risk of hemodynamic instability, we'd put them all in the. We should probably put all those individuals in the unit.
The role of direct thrombolysis.
I'm sorry, what?
The role of direct thrombolysis and this individually because that IR group submassive PEs. So it's not what you guys do. They use of TPA because they use low dose TPA, but it's direct and over 24 or 48 hours.
Yeah. That's the ECOS. This one. The ultrasound is the ECOS. The ECOS EKOS is the company that makes the catheter and makes the machine that delivers the catheter. Theoretically, it's the ultrasound-assisted catheter-directed thrombolysis. So yeah, they use the. My understanding is cardiology is the only one who does it, but I haven't seen it down here. I've only heard about it once at West Bloomfield, so I don't know if anyone other than cardiology does it.
No, IR will do it.
IR do it?
Compete with them, but IR.
Okay.
They follow better. IR, they have a protocol. The door is in, so we're comfortable with IR.
So what do you guys? Do you guys call the surgeons? Do you call interventional?
Interventional.
Most of the cases that come from the emergency room and then IR has been called and they are.
We'll consult IR downstairs.
A lot of those in my opinion go a lot longer. That consult in the ER, they were not even that advanced.
No, they're getting consulted because of RV dysfunction.
Yeah, that's correct. And cardiology is usually the ones that'll put it in for the RV dysfunction. And I think it's because of the data you alluded to that in their studies, the bleeding risk is not necessarily higher.
Yeah. The better question is are there any meaningful clinical outcomes that they're getting? So at 90 days, there's no difference, but are you getting a meaningful outcome at a week? After a week, as I showed you in the things, as I showed you before, individuals even with massive embolism will actually normalize their hemodynamics and normalize their VQ scan. So really, the reason to give therapy is other than heparin, or in addition to heparin, is really because you think their hemodynamics are going to decompensate within a week, and there's a high probability of that. And you have to weigh that versus the risks of thrombolytics or all the other things. All these things that we do aren't benign.
As you pointed out, there isn't any good evidence that if you wait for the hemodynamic compromise that they do any worse if you try to prevent it.
Right. That's the hard part. I think all of us went into critical care medicine because we can do something, and sometimes the thing that we should do is just say, let's just give them heparin and go away for a little while and see what happens. Chris, did you have another question? I'm sorry.
Anything on the mortality outcomes, morbidity outcomes. So, someone is fairly healthy, maybe active, and all of a sudden, 6 months down the road.
Yeah, that would probably be diving into chronic thromboembolic pulmonary hypertension more so than the treatment for submassive embolism. I'll be honest with you, I didn't do a lot of research in that specific area looking for outcomes other than, the outcomes that I cared about, truthfully, are who's going to live longer. Those are the things that I cared about when I was looking for this. But clearly, you're right. There's other things that are important other than how long do you live and what are your limitations, even though you're living. I'm sorry, Julio, go ahead.
So frequently we have a lot of patients that are hemodynamically unstable, have a high suspicion for PE, but we don't have clear documentation of PE. In order to use thrombolytics, do you have to have something that says the patient has a PE, or only with your high suspicion?
Yeah, I would not give thrombolytics to somebody without a high suspicion of PE. You're just asking for trouble. Lots of things can cause hypotension, and lots of things can cause right ventricular dysfunction.
What about a really, really high one? If their creatinine is too high to nail it down.
And they're too unstable to go
And they're
cardiac.
with a normal chest section.
I noticed the case where he was like 500 pounds, and they give thrombolytic with the clinical suspicion of patient dead.
They just
scan the patient. It was just the case they talked to the patient and family, cardiology, vascular surgeon.
Yeah, there was a patient last week who came into West Bloomfield who was heavy and also had right ventricular dysfunction. They gave thrombolytic therapy and ultimately sent the patient to the CT scanner. Initially proposed to be hemodynamically unstable, and the CT scan was clean. Now, when that guy's got a 2% chance of bleeding in his head, how are you going to explain to his family how I gave thrombolytic therapy in the absence of a diagnosis? Heparin, clearly, but I feel really uncomfortable giving somebody thrombolytics without having a diagnosis. Anybody else? Questions? No?
Anything else about decrease in the blood pressure from a baseline, not particularly by definition less than 90 systolic?
It's greater than 40. So a massive embolism is designed by blood pressure of less than 90, or a hemodynamically, or somebody who's dropped 40 millimeters of mercury. Yeah, and it's got to be for 15 minutes, so it can't be just transient or something like that, and has to be not related to other potential causes of hypotension. So it can't be a new arrhythmia, it can't be sepsis, it can't be something like that. Well, thank you. I appreciate your time.